Hello again, this is Dr. Zwain, Associate Professor of the Department of Pharmacology and Toxicology here at AUB. Today we're going to go over the drug therapy for dyslipidemia. So please, in order for you to understand this lecture, I need you to go over the lipoprotein metabolism lecture, which is already posted. If you need any guidance or if you have any questions, feel free to email me at fz15@aub.edu.lb. And again, I'll be more than happy to follow you on LinkedIn and Twitter so we can share each other's achievements, especially if you're interested in doing some research. So by the end of this lecture, I expect you to be able to define dyslipidemia, understand why we treat dyslipidemia, interpret and analyze the atherosclerotic cardiovascular disease risk assessment, very important assessment risk, and describe dyslipidemia management, list the dyslipidemia drug classes, different drug classes, and distinguish between dyslipidemia drug classes and their mechanism of action.
Now, it's important to understand the lipoprotein metabolism in order to understand the direct and indirect effects of dyslipidemic drugs. So we're going to touch base on lipoprotein metabolism now in order to refresh our memory. It's mainly, the lipoprotein's metabolism is mainly like a shuttle route that picks up things on its way and drop things as well in a very selective manner. Each shuttle has a specific job. So we'll start by the exogenous lipoprotein metabolic cycle. There are basically two types of pathways. We have the exogenous pathway and the endogenous pathway. In the exogenous pathway, it's based on all the lipids that we eat that comes from diet, triglyceride and cholesterol here. Once we have a fatty meal, the intestinal cells, they package dietary cholesterol and triglyceride into chylomicrons. And chylomicrons acquire the ApoC2 and ApoE proteins from HDL. They go into the circulation, into the specific tissues that needs basically the triglyceride, the adipose tissue, and the muscle tissue. On these tissues, we have an enzyme called lipoprotein lipase. So lipoprotein lipase, what it does, it interacts with ApoC2 on chylomicrons and release all the fatty acids to be uptaken into the cell, and the glycerol, which is released into the plasma and goes back to the liver to be metabolized or used to form glucose molecules. So once the CM is digested, it's converted into what we call the chylomicrons remnant. So it's less rich in triglyceride, more rich in cholesterol. Most of the triglyceride was taken by the tissues. The CMR is then taken back to the liver through the ApoE receptor, where the cholesterol is released and it can go into the biliary acids. We have here something called the enterohepatic circulation. It goes in the intestine, goes back to the liver. I'm sure you talked about that in other lectures. So on the other hand, we have another pathway called the endogenous lipoprotein metabolic pathway. So here the CM, when we talked about the CM in here, we talked about chylomicrons. Chylomicrons basically takes triglyceride from the diet to the tissue, okay, and cholesterol from the diet back to the liver. In the endogenous pathway, it's basically the liver-derived fatty acids, primarily coming from lipogenesis, and if we have an excess of free fatty acids, together they will form something called the VLDL, or very low density lipoprotein. Once VLDL is synthesized, also acquire ApoC2 and ApoE from HDL, same process as chylomicrons. It's released into the circulation. The circulation, it undergoes the same process as chylomicrons. Lipoprotein lipase here would take the triglyceride need and release the glycerol, take free fatty acid into the cells and convert VLDL into something called the intermediate density lipoprotein. Now, IDL is not very stable. 50% of ADL is taken back to the liver through the ApoE receptor, and the other 50% is converted by hepatic lipase into the famous LDL, or low density lipoprotein. Now, the role of LDL is to transport cholesterol to the tissues. You know, the tissues also need cholesterol. They don't only need triglycerides. So the LDL takes the triglyceride, give it to the tissues, and it shrinks into a molecule, IDL, that has more cholesterol than triglyceride, which is then converted by hepatic lipase into low density lipoprotein rich in cholesterol. The LDL is then bind to the LDL receptor, which is located on the peripheral tissues. It's converted to cholesterol, and basically what happens at this point, it's internalized. So once it binds to the receptor, it's internalized into the cell, where cholesterol is released and taken by the cell. Now, like anything really, if you have it in excess, you don't need it. So the cell will say, okay, if I have a lot of cholesterol here, I don't need it, I'm going to release it. Then it's released as free cholesterol into the circulation. It's taken up by HDL, the good cholesterol. That's why we call it good cholesterol, because it takes the excess of cholesterol from the tissues and esterify it, put it in its core, and take it back to the liver to be basically either metabolized or released into the biliary circulation. Now, what is dyslipidemia? I'm pretty sure that you've heard of this term before, and or at least you know someone in your family, or you know someone who knows someone that suffered from dyslipidemia. Dyslipidemia is basically an increase in triglyceride or cholesterol levels in the blood, and there's many causes for it. The most common one is basically a fatty diet, lack of exercise, and sedentary lifestyle. Now, as you age, your metabolism decreases, and if you stay on a fatty diet with lack of exercise and a sedentary lifestyle, the risk of dyslipidemia increases. Now, of course, this is not always the case when you are genetically predisposed, such as family hypercholesteremia that could come at you at younger age with abnormal high level of cholesterol. Now, certain drugs do also have effect. They can cause dyslipidemia, such as cortisone and steroids. And of course, we're talking here about long-term treatment, not acute treatment. It's been shown that they can cause moderate hyperlipidemia. Other disorders, metabolic disorders, of course, since we're talking about endocrinology here, we're talking about metabolic syndromes, diabetes, polycystic ovarian syndrome, and alcoholism. Of course, alcohol, if you know, in basic biochemistry, alcohol causes by itself, when you consume it, 50% reduction in lipid metabolism. So the long-term consumption of alcohol also is associated with dyslipidemia and fatty liver. Now, the AHA, the fasting cholesterol and triglyceride guidelines, this is a normal cholesterol test. It's called a complete cholesterol test. It's referred as lipid panel or lipid profile. It's this one right here. We call it the lipid profile. It includes the calculation of 4 types of fat in your blood. We're talking about total cholesterol, HDL, LDL, and triglyceride. Now, total cholesterol is basically the sum of your blood's cholesterol content, and it's a good optimal when it's less than 200 milligram per deciliter. The high-density lipoprotein, also known as the good cholesterol, and we're gonna see why as we go, mainly because it helps carry away LDL cholesterol and preventing the buildup of cholesterol in your arteries, and this is a main cause of coronary artery disease development. The good optimal is when it's higher than 60 milligram per deciliter. And the LDL, also known as low-density lipoprotein cholesterol, it's known as the bad cholesterol because too much of it in your blood will cause a formation of a plaque or atheroma plaque that increase the risk of coronary artery disease formation. And the good and optimal level is less than 100 milligram per deciliter. And of course, you have triglyceride, which is the type of fat in blood. You know, when you eat, your body converts all the calories that you don't need in a form of reserve, and it's triglyceride. They're stored in fat and in fat cells. So high triglyceride levels are associated with several factors. Pretty much, you know, when you're talking about type 2 diabetes or overweight people, they eating too much and have the sedentary lifestyle, they can gain a lot of weight and store their energy into fat, which increases the risk of dyslipidemia. So triglyceride levels, the good and optimal levels are less than 150 milligram per deciliter. So why we treat dyslipidemia? Simply because a high level of lipids in your blood and consistent high level of lipids in your blood, not basically after a meal, is associated with high risk of coronary heart disease. When I'm talking about coronary heart disease, I'm talking about atherosclerosis and the plaque formation and high risk of this plaque to break and cause an ischemia, also known as myocardial infarction, which could be fatal. So patients with elevated low-density lipoprotein is very common. And reduction of LDL, when you do lipid-lowering therapy or reduce LDL, the coronary heart disease decreases by 30 to 40%. And this is big. Even the patients that have low HDL and normal LDL. So if you have a normal bad cholesterol, the LDL, but low good cholesterol, the HDL, the lipid lowering therapy also reduces coronary disease by 20 to 35%. So it's important not only to bring back LDL to normal, but it's important to keep HDL level at normal range as well. If you don't have any issues with cholesterol levels, if you have normal LDL, normal HDL, hypertriglyceridemia is also associated with a big risk. Now, if it's over 1,000 milligram per deciliter, now this is not awfully common, of course, you have high risk of pancreatitis. Moderate elevation, which is most commonly seen, it's between 150 and 400 milligram per deciliter. And it's often a part of the type 2 diabetes or any syndrome of insulin-resistant obesity and hypertension. Of course, the risk of coronary artery disease is high. Even the total cholesterol is normal, as we said, but it's also high or higher when dyslipidemia is associated with comorbidities. So let's say an individual have dyslipidemia, whether it's an increased LDL, decreased HDL, or increased triglyceride, or all of them. If this patient is a smoker, if he has hypertension, if he has type 2 diabetes or any type of metabolic syndrome and insulin resistance and high weight or obese, all these risk factors increase the risk of coronary artery disease development. So this is another reason why it's very important to interfere and treat dyslipidemia, because you see, this is published by the National Cholesterol Education Program that shows here that the relative risk for coronary heart disease is almost 100% proportional with LDL cholesterol level. So higher is the LDL level in the blood, higher is the relative risk of coronary heart disease. This basically emphasizes the importance of an interventional therapy and drug-based therapy in order to bring LDL levels back to the normal range and reduce the risk of coronary heart disease development as well. Another reason why active treatment is necessary in a dyslipidemic patient. If you look at this graph here, the prevalence of various risk factors of CAD. So patients that have, let's say, a family history of coronary artery disease are at 10% risk of developing coronary artery disease. With smoking, the risk increased to 17%. With tobacco consumption, general tobacco consumption, it increases to 19.5%. With diabetes, it increases to 46%. And then 47.5% with obesity, 54% with hypertension, 59.5% with metabolic syndrome, which makes sense because metabolic syndrome is also related to obesity and to diabetes. But look at that. In dyslipidemia, the risk increased to 93%. So dyslipidemia by itself is among the highest risk factors in CAD prevalence. So it's very important when you have a patient, a dyslipidemic patient that is at high risk of coronary artery disease development, to start treatment. Multiple risk factors are used in or included in the calculation of atherosclerotic cardiovascular disease risk assessment. The risk factors are the sex, male or female, because gender risk factor varies between males and females. The age, the older you are, higher is the risk. So the age range in calculating the 10-year risk assessment is between 20 and 79, but in calculation of lifetime risk assessment, it's between 20 and 59 years. The race, basically related to genetic background. For instance, African American are known to have higher risk of cardiovascular disease development when compared to white and other races. Cholesterol levels, of course, you look at total cholesterol and HDL levels. Systolic blood pressure, you have to define whether these individuals do have hypertension or not, because hypertension on its own is a high risk of CAD development. And whether, let's say, if this individual do have hypertension, does he have an active treatment of high blood pressure? It's important to know. Whether we have diabetes or not. Diabetes is a very high risk factor. And whether he's a smoker. So combining all these risks together will give us a clear idea on the risk of ACVD in this patient. Now, it's important to note that from 20 to 79 years old, the risk is used to for 10 years assessment. And for patients or individuals who do not have any clinical ASCVD, because if they do have clinical ASCVD, they must be on active treatment because they are at high risk already of CAD development. And if individuals, if you look at individuals and their lipid profile, if their LDL levels are higher than 190 milligram per deciliter, regardless of the risk factors, these individuals are at very high risk and must undergo an active treatment immediately. So this is an example of the ASCVD risk estimator. It's actually a calculator. You can find it on this website developed by the American College of Cardiology, and you can play with it and fill out any data you want here to check the risk assessment. So all you need to put is the age, the sex of the individual, the race, the blood pressure, the total cholesterol levels, HDL, LDL, and whether the individual has a history of diabetes, whether he's a smoker, on hypertension treatment or not, on a statin, which is a dyslipidemic drug, on aspirin, anticoagulation therapy. And also have the option to compare the risk of this individual with previous visits. So you have this question: do you want to refine current risk estimation using data from previous visit of this individual? So it's really nice. You can just play around with it and get an idea of how it works. Now, the optimal ASCVD risk calculator provides optimal risk estimates for individuals with age ranging from 40 to 79 years old, which makes a lot of sense. One of the reasons is because, a lot of patients with coronary artery disease, or most of the patients with coronary artery disease, and the risk of coronary artery disease are between 40 and 79 years of age. So we do have a lot of data on these individuals. Using all these data and all these cohort, we can strengthen the risk estimates using this calculator. Now, after doing the ASCVD risk assessment, and as we said, it only provides optimal risk estimates for individuals between 40 to 79 years of age. If you look at the 10-year risk assessment, and when we're talking about risk assessment, again, we're talking about all these individuals that do not have ASCVD. If they have ASCVD, there's no point to look at the risk assessment. They must be on treatment. But it's we can get different results, and in percentage, the risk is in percentage. So if the ASCVD risk is less than 5% or is borderline, let's say between 5 and 7.4%, these individuals, they should follow a preventive therapy or lifestyle management, so a drug-free therapy. No need to put them on drugs, okay? So because the risk is either borderline or low. On the other hand, if these individuals are at intermediate risk or at high risk, intermediate risk means that it's higher than 7.5% and less than 19.9%. And high risk are the individuals that are at high, more than 20% risk of ASCVD. Now, these patients or these individuals require, in addition to a lifestyle management, a drug therapy. Because, of course, studies have shown if you do preventive therapy or lifestyle management on its own, it's not gonna bring the risk down to borderline or low risk. So in general, they require a drug therapy in order to bring the risk down below borderline. So if you look at the American Heart Association ASCVD risk assessment guidelines, first thing you do, you ask the question, does the patient have existing clinical ASCVD? If he does, like we said before, there's no point to do a risk assessment. We have to refer him immediately to the specific or related AHA-ACC guidelines. Now, if the patient doesn't have a clinical ASCVD, so we have to assess whether he is at risk or not. So we look at the age. Is the patient between 20 or 79 years of age? If not, it means that he's either less than 20 or more than 79 years of age. And we know that the risk assessment is optimal for patients, or is designed for patients between 20 and 79, and is optimum for patients between 40 and 79 years of age. So we refer them to the pediatric geriatric guidelines specific for these patients. Now, if the population or the patient that we're talking about is between 20 and 79 years of age, so the perfect fit for the ASCVD risk assessment, so we assess the traditional 10-year risk assessment for this population, and we know that it's more powerful when there is 40 and 79 years of age, because we do have a lot of cohort equations and a lot of data pertain to this population. Now, if the risk is high, if it's higher than 7.5, so it's not low, it's not intermediate, we're getting into the, it's not low, it's not borderline, we're getting more into the intermediate and high risk. So we have to send this population to these particular guidelines. So these patients, or this patient, has to be on lifestyle management and a drug therapy in order to bring back his risk to borderline or low. If the patient has a low 10-year risk, less than 7.5%, so we're borderline or we're low. Of course, it's gonna follow the guideline of lifestyle management and prevention to basically prevent this risk of going up to the intermediate or up to the high level. So what we do at this point, we assess 30-year or lifetime risks, specifically if the patient fit the category of 20 to 59, because this is optimum for lifetime risk communication, risk assessment, and we communicate the risk to the specific guidelines. Now, how do we manage dyslipidemia? We have two ways to manage dyslipidemia. We could manage it through a drug-free therapy or drug-based therapy or both. But all depends on the patient that we are treating. If the patient is at low or borderline risk, as we said, we can put them on a lifestyle management and preventive therapy. And this is the base of drug-free therapy. If the patient has high risk or intermediate risk or already is diagnosed with clinical ASCVD, they must be on a drug therapy. But this doesn't mean that if he's a drug-based therapy, he doesn't follow a lifestyle management. This is important. Most of the patients that are on a drug therapy, they follow a good lifestyle management. Now, how do we treat a patient with drug-free therapy? What is drug-free therapy? It's basically eliminating all the risk factors that are increasing this ASCVD risk. So they have to follow a very good diet, very restrictive diet. Of course, when we say a restrictive diet, it has to be very low on fat, low on cholesterol. Cholesterol must be less than 300 milligrams per day, because we know that 1/3 of cholesterol is acquired by food. Low-fat diet, less than 30% of the total calories. Low in saturated fat, and it should be less than 10% of calories, because saturated fat are known to block LDL receptors and stimulate cellular cholesterol production. That's why in Western diet, we always say that saturated fat are bad. And cessation of smoking. Smoking is a factor. And you have, of course, to exercise. The more calories you burn, the less you're gonna stock up on fat in your body. At the same time, you have to eliminate all the aggravating factors. If the patients have comorbidities such as diabetes, hypothyroidism, hypertension, or even have alcoholism, they have to be very well managed to reduce the risk. We know that alcohol by itself, even if it doesn't reach the stage of alcoholism, inhibits 50% of lipolysis, so it stimulates the fat deposition. So it's very important to take all these things into consideration when following a drug-free therapy. And again, the drug-free therapy is important even as an adjunct to drug-based therapy. Now, if the patient is at intermediate or high risk of ASCVD development, or the patient is already clinically diagnosed with ASCVD, we must put the patient on a drug-based therapy for two reasons. First, if the patient is at intermediate or high risk, we have to make sure that we bring the risk back to borderline and low level to prevent any ASCVD development. Or if the patient is already clinically diagnosed with ASCVD, we have to make sure that this disease doesn't progress, right? You have to stop the plaque from forming. You have to make sure that it resolves and it doesn't grow and lead to, for instance, to a myocardial infarction or something fatal. So this is where the drug therapy intervenes. It's very important. Now, these drugs are divided into 9 classes. We have the statin drug therapy and non-statin drug therapy. So 1 class of statin and 8 other classes of non-statin drug therapy. And the reason why we divide them into 2 different groups, because statin is the most widely prescribed drug in managing dyslipidemia. It's cheap, it's very effective, and it's basically tolerated by most of the population. The other drugs, the other list of drugs that we see here are more used either for specific cases, like for example, niacin and fibric acid and omega-3 are used to manage patients with very high triglyceride levels, or inhibitor of micros MTT here, or ApoB100 synthesis that are used to manage patients with family hypercholesteremia where statins are not effective, or the drugs are used as an adjunct to statin. If, let's say, the patient has high risk of developing adverse effect with statins, we can reduce the dose of statins and put another drug as an adjunct therapy from this list, or even as a monotherapy, as a drug of choice if statins cannot be used at all. We're going to talk about this in details and when we hit the drugs now. So starting with statin drug therapy being the most widely used drug to manage dyslipidemia. Of course, pharmaceutical companies, knowing the importance of this drug, they jumped in and produced different types of statins: high intensity statins, moderate intensity statins, and low intensity statins. Now, the drug of choice depends on the desired intensity and the patient risk factor. So you have to think as a clinician, what is the degree of desired LDL lowering effect? It could range between 30 to 60% depending on whether you want to use high intensity statins or low intensity statins or moderate intensity statins. Now, of course, a rule of thumb here, I don't need you to know all these drugs, okay? I just need you to know the classes of the drugs. I don't care about names at this point. I think later on in life you're gonna know them by heart. Now, what's the mechanism of action of statins? Statins are nothing but structural analogs of HMG-CoA. And HMG-CoA is a substrate of HMG-CoA reductase, which is a rate-limiting step enzyme in cholesterol synthesis. So by basically competing with HMG-CoA, we block the cholesterol synthesis pathway. And we know that 2/3 of our body cholesterol is synthesized within our body, and mostly in the liver. So what happens at this point? You're going to have a reduction in endogenous hepatic cholesterol synthesis. And if you have a decrease in cholesterol levels, let's say you have a drastic decrease in cholesterol level, what's going to happen? The system is going to sense that we have lack of cholesterol. And if we have lack of cholesterol, what the cell's going to do? They're going to increase in a feedback mechanism the expression of LDL receptors, right? If you have a decrease in cholesterol, the cells say, hey, I need more cholesterol. Let me increase the LDL receptor. By increasing LDL receptor, you're going to start collecting more cholesterol, more LDL from the blood, and this will basically decrease the LDL levels and the cholesterol in the blood. That's what we see here. Now, at the same time, we know that cholesterol is a very important component of the LDL formation in the liver. If you have a decrease in cholesterol synthesis in the liver, you're going to have a decrease in VLDL formation. And subsequently, because VLDL is converted to LDL, you're going to have also a decrease in LDL levels. So if you have a decrease in VLDL levels, which is rich in triglyceride, you're going to also have a decrease in triglyceride. You're seeing how much of a good effect statins have on the lipid profile. And if you have a decrease in triglyceride levels, you're going to have, as an effect, an increase in HDL levels. And we're going to see how in the next slide. So one of the most adopted explanation of why the decrease in triglyceride will increase HDL availability is based on the following graph. I'm sure that you're familiar with the basic lipoprotein metabolism already. So what you're seeing here, you have a liver. The liver normally produces the VLDL by assembling triglyceride and cholesterol together, packaging them through VLDL, and VLDL goes on a journey to deliver triglyceride and cholesterol to the peripheral tissue from VLDL, IDL, LDL, which we talked about before. And then you have the HDL, which basically is matured. It goes from nascent HDL into an active form of HDL by acquiring cholesterol from the macrophage. This cholesterol is esterified into cholesterol ester through an enzyme called alcat. It goes and forms the HDL3. And now with the HDL3 that's rich in cholesterol, cholesterol ester, what it does, it starts exchanging the cholesterol with triglyceride from other lipoprotein. So there's two ways of HDL to take the cholesterol back to the liver. It either go directly, it binds to the SRB1 receptor and it unload the cholesterol, and then it goes back to HDL3 to pick up other cholesterol, or it exchanges it directly with other lipoprotein. For instance, you have here an exchange CETP. It's known as cholesterol ester transfer protein. It gives the cholesterol to the lipoprotein and picks up triglyceride from these lipoprotein. So the cholesterol that goes to these other lipoprotein, they basically follow the same route back to the liver. For instance, if it's VLDL is transformed into LDL, and LDL goes back, bind to the receptor, internalize, and cholesterol is going back to the liver. It's very simple. I'm sure you went through this. So the point is right here. What happens here? So here, in this area right here, if you have very high level of the LDL and LDL, and this is something that is common with patients in dyslipidemia. So that means that you have a very high exchange rate going on here. So the cholesterol is given up by HDL and triglyceride is taking back in exchange. What does that do to HDL? It makes it inefficient. It goes up in size, and you're going to have more defective HDL that are unable to collect more cholesterol. So what happens at this point when you give statins? What's going to happen? You're going to have a decrease in VLDL formation, less VLDL formation. If you have less VLDL formation, you're going to have less of this exchange going on, which means you're going to have more HDL3 available. Okay, this, and also there is another explanation in addition to this, that we have an increase in, with statin, they notice an increase in ApoA1 mRNA expression, which is very important in the formation of HDL. Now, going through the basic of pharmacokinetics of statins, the absorption, distribution, metabolism, and excretion. Of course, I don't want you to know the pharmacokinetics of each drug. I gave examples here, but I just need you to know the general information about the pharmacokinetics of statins. So 30 to 85% of statins are absorbed following PO per os, which is good. So it has very good oral bioavailability. But once it's delivered to the liver, there's an extensive first pass effect mediated by a transporter known as OATP. OATP, for those of you who don't know, is an organic anion transporting polypeptide. So what it does, it basically collect the drugs. It's expressed on the basolateral membrane of hepatocytes and transport the compounds into the hepatocyte for biotransformation. So after the 30 to 85% being absorbed, you have the first pass effect, and what you're left with is 5 to 30% bioavailability of the administered dose. And this, of course, depends on the type of drug that's being used, the type of statins. The bioavailability varies between different statins. You have 95% plasma bound for most of them, with the exception of pravastatin of 50% protein bound. Now, most of the statins are short-acting drugs with half-life ranging between 1 and 4 hours. And liver biotransformation dominates. Of course, most statin metabolites are eliminated in the feces, and they follow a CYP3A for metabolism mostly, the most common form of CYP. 7 to 10 days is the maximum delay in order to have an optimal therapeutic effect, and the dose is preferably giving at night for simple physiology, because hepatic cholesterol synthesis, everybody knows, it peaks between midnight and 2 a.m. So it's preferred to give this dose at night. So again, this is how statins work. They basically block the pathway that leads to the synthesis of cholesterol by blocking the rate-limiting step enzyme known as HMG-CoA reductase, because statins are nothing but analogs of HMG-CoA. So usually in the liver, let's say, or any site of cholesterol synthesis, you have 3 acetyl-CoA that condense together to form HMG-CoA, and HMG-CoA go down through this path to synthesize cholesterol. Now, why I'm showing you this? Because when you read more about statins, you're going to realize that statins don't only reduce lipids, but they also have other protective effects. These protective effects are characterized by improvement in endothelial dysfunction, antioxidant effects, stabilization of plaque formation, and also anti-inflammatory effect. And the reason behind it is because by blocking this path, you're going to block the formation of these byproducts, such as mevalonate, farnesene, and squalene. And all of these byproducts do have bad effects on the vasculature. For instance, mevalonate decreases eNOS. eNOS is important in the formation of NO, and we know how NO is protective to the vessels. Decrease in angiogenesis. Others, such as this byproduct here coming from farnesene, it decreases eNOS formation, increase endothelin 1, which is a vasoconstrictor, and increase oxidative stress. So if some of you look into statins, or if anyone asks you why statins are protective outside dyslipidemia, it's because they also inhibit the formation of these byproducts. So statins are generally well tolerated. They are the most widely used dyslipidemic drugs because they're very efficient and they are cheap, basically, and people can afford them. One of the common side effects is hepatotoxicity, of course, given the drug is metabolized in the liver. And if patients have liver failure or predisposed to liver damage, we should be careful in monitoring their liver enzymes. Another major adverse effects of statin, and very common with statin, is myopathy. It's really broad, but it ranges. It could be mild to severe. It depends on the dose. It depends on the age and whether the patient that's on these drugs have kidney or liver injury. Because usually what happens, higher is the dose in the blood, higher is going to be the risk of myopathy. And patients who suffer from liver and kidney injury, they don't excrete or biotransform the drug efficiently, which increase the risk of plasma concentration being delivered to the skeletal muscle and causing myopathy. On the other hand, also, geriatric populations are on polypharma. And when we say polypharma, we mean that we have a lot of drugs on board, so the risk of drug-drug interaction is high that could decrease the excretion or the metabolism of statins, increasing therefore the level of statins and increasing the risk of myopathy. Statin, for sure, is contraindicated in pregnancy or breastfeeding. Now, when you talk about any drug therapy, you have to be basically aware of potential drug-drug interaction. So, and when we're talking about statins specifically, you have to be aware of drugs that increase statin's plasma concentration, because we just said that higher is the statin plasma concentration, higher is going to be the risk of myopathy. And it's not a desirable side effect. And most of patients do not comply with the statin when myopathy develops. So one of the drugs, gemfibrozil, it's a fibric acid derivative. It's a non-statin drug, actually, that we're going to be talking about later on in this lecture. It inhibits statin uptake by OATP. We said earlier that OATP is this transporter that takes statins to be biotransported within the liver. So if you inhibit OATP, statins will not be going to take in the liver. This will double statin concentration, and you're going to have high risk of myopathy. And of course, we also said that CYP3A4 is the major CYP involved in the metabolism of statins. Any drugs, and we know that there's a lot of drugs that inhibit CYP3A4, could increase statins bioavailability and subsequently statins blood concentration, which will lead to a high risk of statin toxicity. Of these known compounds, we have macrolide, azolantafungal, cyclosporin, nefazodone, and others, and grapefruit juice, of course. If potential DDI exists, you have to switch to non-CYP3A4 metabolized statins, and we have a couple of them like rosuvastatin, fluvastatin, and pravastatin. So we have some options here if the patient is on polypharma and there is a high risk of drug-drug interaction. Moving now from statin drug therapy to non-statin drug therapy. We're going to start by talking about the bile acid sequestrants, which are actually fun drug to study. There are three type of bile acid sequestrants known. We have the cholestyramine, cholestyramine, and cholcibilam, which all basically have the same mechanism of action. These are resins-based molecules, highly positively charged, which bind to negatively charged molecules. So their bulk size allow them to be ingested into the GI tract. They go all the way down without being absorbed, which is very good. So this decreases the risk of them being absorbed and decreases the risk of toxicity as well. So what they do, they bind to anything that's negative. And we know very well that the bile acid or the bile salts are anions. They're negatively charged, and once they bind to these resin molecule, they basically go down in the stool. What happens at this point? What's the therapeutic effect? So we're going to observe a decrease in bile acid reabsorption. We know very well that the enterohepatic circulation allow around 95% of bile acids being reabsorbed. And what's the major content of bile acids? What do we have a lot in bile acids? We have cholesterol, and our target is to decrease cholesterol, right? So we're going to have a decrease in hepatic cholesterol content once we give these drugs. And as a result, similar to what we talked about in statins, the cell's gonna notice that we're gonna have a decrease in cholesterol. We need cholesterol. What are they gonna do as a feedback mechanism? They're gonna increase LDL receptor synthesis, which subsequently will decrease LDL level in the circulation, because more LDL receptors will attract more LDL from the circulation, and we're gonna have a decrease in cholesterol. However, what's gonna happen as another feedback mechanism, the liver will start increasing the synthesis of cholesterol and triglyceride. So this could offset the effect. So that's why it's very important, if you want to have a great effect with bile acid sequestrant, to put them as an adjunct therapy to statins. Why? Because the statins will block the synthesis of cholesterol, and at the same time, you're giving bile acid sequestrant that block the enterohepatic circulation and reabsorption of cholesterol. So we're going to have a very good effect. However, you should be using them with caution in case of hypertriglyceremic patients. Now, therapeutically, bile acid sequestrants are highly recommended in pediatric patients since they're very safe. They're not absorbed by the GI tract. They don't go to the circulation, so toxicity is minimal at this point. And as we said, it could be a perfect adjunct therapy to statins if statin monotherapy is sufficient. Not only if statin monotherapy is sufficient, if statin therapy is causing, let's say, unbearable side effects that prevent the patient to comply with the medication, you can decrease the dose of statins and give them bile acid sequestrant in order to reach the optimal effects. Adverse effects and drug-drug interaction. These drugs are safe in general, as we said, but they're contraindicated when we have severe hypertriglyceremic patients, since TG is an increase in TG or triglyceride is a potential side effects, of course. Side effects include bloating, dyspepsia, constipation. These are polymeric bulk resins. I mean, you would definitely expecting that they upset the stomach. Hypercholemic acidosis is also one of the side or potential side effects, and there's a reason behind it, because you know what's metabolic acidosis, or what's hyperemic acidosis? Metabolic acidosis, right? And it's associated with a normal anion gap. So when you have a decrease in plasma bicarbonate concentration, you basically reach a phase of hypercholemic metabolic acidosis because you have loss of base. So what happens at this point? It could be due to either renal loss of bicarbonate or gastrointestinal loss of bicarbonate. So in this case, in case of bile acid sequestrants, because they are positively charged, they bind to the negatively charged bicarbonate and they decrease bicarbonate level, leading to a loss of base and a high risk of hypercholemic acidosis. It can definitely interfere with the absorption of many drugs. So if you have polypharma on board, you have to be careful. This is a polymer that can absorb negatively charged or other molecules. So drugs like thiazides, beta blocker, and digoxin should be used carefully with these drugs. And it's always preferred to give these drugs a couple hours before or after any medication to prevent any potential drug-drug interaction. Another non-statin based drug used in the treatment of dyslipidemia is niacin. Niacin actually is a form of the vitamin B3 complex. You know, the vitamin B3 complex comes into three forms: the nicotinamide, the NAM, and the nicotinic acid, which is niacin, and nicotinamide riboside, which is NR. So niacin is one form of the B3 complex. And usually you can find this drug over the counter. It's in its crystalline form, but an extended release form, it requires a prescription. Now, niacin main mechanism of action is on adipose tissue. Why is it used as a dyslipidemic drug? Actually, what it does, it inhibits the G protein coupler receptors on the adipose tissue, the GI type, and which subsequently lead to CAMP inhibition. By inhibiting the cyclic AMP, you inhibit the HSL lipase, which is a hormone-sensitive lipase. By inhibiting hormone-sensitive lipase, you inhibit lipolysis. By inhibiting lipolysis, you're inhibiting the breakdown of fat. So you're going to have a decrease in free fatty acid released into the circulation. Less free fatty acid released in the circulation means less free fatty acid going to the liver. So the liver will not get much of free fatty acid and will not be able to synthesize triglyceride. So at the level of the liver, you're going to have an inhibition of synthesis and esterification of free fatty acid. At the same time, the niacin also causes an increase in lipoprotein lipase activity. And we know that lipoprotein lipase is an important enzyme in basically metabolizing chylomicrons and VLDL and taking the triglyceride load from these molecules, right? At the same time, it also limits ApoA1 clearance, and ApoA1 is a major protein in HDL formation, which could subsequently lead to an increase in HDL, the good cholesterol. This is just to visualize what we were talking about regarding niacin. So you see, niacin works by inhibiting the hormone-sensitive lipase, right, located at the adipose tissue. We said that this is a G protein coupled receptor, a GI type. And what it does, it inhibits the breakdown of triglycerides. So when you break down you inhibit the breakdown of triglyceride, you're going to prevent the free fatty acid from being released. And this will lead to a decrease in fatty acid release from adipose tissue, decreased fatty acid delivery to the liver, and subsequently you're going to have a decrease in liver triglyceride synthesis. And triglyceride is a very important component of VLDL formation. If you have less triglyceride, you're going to have less VLDL production, less VLDL being released to the circulation, and less LDL formation, because we know that LDL is basically the end product of the LDL metabolism in the circulation. On the other hand, what niacin does, it actually activates lipoprotein lipase. By activating lipoprotein lipase, you have the LDL in the circulation. What they're going to do with them and chylomicron, they're going to get the fatty acid from the LDL chylomicron, turning them into remnants. right? And this also will help in decreasing the triglyceride level in the blood and cholesterol level in the blood. And as we said earlier, they also have an effect in increasing or in limiting ApoA1 clearance, which basically means you're going to have an increase in HDL, the good cholesterol. So the major effect of niacin is on triglyceride. You can see that basically after you understand the mechanism of action, you can now tell that yes, it has a major effect on triglyceride. So it's mainly used to treat patients that have hypertriglyceridemia and also elevated LDL, because look at that. You have a decrease, up to 50% decrease in triglyceride synthesis. Reduced VLDL formation, because less of triglyceride is synthesized in the liver, will reduce subsequently LDL up to 25%. So increasing LPL activity also increase VLDL and chylomicron clearance and increase HDL level, as we said, by limiting ApoA1 clearance. It's the most effective drug in increasing HDL, actually, in up to 30 to 40%. It has a very short half-life. That's why you can use it over the counter, but you cannot use it in extended release. It's metabolized by liver and excreted in urine as an unchanged form, depending on the dosage or nicotinic acid. So the therapeutic use, as we said, mainly to treat patients with hypertriglyceridemia and elevated LDL. It doesn't improve statin treatment as adjunct, actually. A lot of trials studied this and realized that, well, when you combine niacin with statins, it doesn't improve statins therapy. So it's more effective monotherapy when patients cannot comply with statin therapy. You have to be careful while using niacin because it can cause hepatotoxicity at very high dose. And the reason why it's not also being used as an adjunct therapy to statin, because trials showed that it increased the risk of myopathy when used with statin. So it's not recommended. Be careful with this point. One of the also major side effects is flushing and dyspepsia. You know, and this is really very bad because it limits the compliance. So a lot of patients do not take these drugs because of these two side effects. And these side effects are mainly due to the effect of niacin on keratinocytes and epidermal cells, because they release what's known as prostaglandin. By activating the G protein coupled receptors, they release prostaglandin, and prostaglandin is a vasodilator, so they cause this vasodilating that subsequently lead to flushing. It can cause insulin resistance, so we have to be careful when used with hyperglycemia, so you have to use and caution with patients that are diabetic, and contraindicated in gout patients since also it increase uric acid levels. Continuing with non-statin based dyslipidemia drug therapy, we're going to talk now about the inhibitor of cholesterol absorption. Well, which makes a lot of sense. Basically, you know that 2/3 of cholesterol is synthesized in the liver and 1/3 is ingested. So what if we can inhibit the cholesterol that's ingested and limit the absorption of cholesterol through the intestines? And that's what this drug does. Ezetimibe was a very, very famous drug back in clinical trials in the last decade. So this drug, the mechanism of action is simply inhibits the NPC1L1 of the jejunal enterocytes, which is basically a polytopic transmembrane protein in the apical membrane of small intestines, and its job is to absorb cholesterol. So this would decrease cholesterol absorption by up to 54%. What happens at this point? If you have decrease in cholesterol coming in from food, you're going to have a decrease in chylomicrons formation, right? Because chylomicron is formed from triglyceride and cholesterol coming from food. And this will lead to a decrease in chylomicrons remnant delivery to the liver. Subsequently, as a feedback mechanism, you're going to have an increase in LDL receptor synthesis and more LDL clearance. You're going to have a clearance up to 20%, between 15 and 20%. It's a highly hydrophobic drug. 70% of it is excreted in feces through the enterohepatic circulation, so it keeps going into that circulation. And the absorption is diminished with bile acid sequestrant. So we have to be very careful not to combine it with bile acid sequestrant because it could basically diminish its effect. So ezetimibe is an excellent monotherapy if patients are intolerant to statins. Actually, very widely prescribed drug in statin intolerant patient. But also, it's very effective if combined with statin. Actually, the combination ezetimibe simvastatin is an actual drug marketed by Merck, and it's very widely prescribed. Why it's very widely prescribed and why is it effective? Because if you think about it, they have additive effects together. If ezetimibe inhibit cholesterol reabsorption, it's going to increase cholesterol synthesis in the liver, which is going to be inhibited by statin. And if statin inhibit cholesterol synthesis in the liver, it's going to increase cholesterol reabsorption in the guts, which is inhibited by ezetimibe. So it's a win-win situation in decreasing the total level of cholesterol. The adverse effect is a rare allergic reaction could be seen, and you have to be careful, yes, from the statin side effects when you use the combination of these drugs. So usually it's very important to worry more about the statin side effects rather than ezetimibe side effects on its own, especially when you have the combination of these two drugs. To summarize where we reached so far, this is a graph showing the mechanism of action summary of statins, resins, ezetimibe, and niacin. So very quickly, now we know that the statins works by inhibiting the HMG CoA reductase. By inhibiting this, they're inhibiting a rate-limiting step in the synthesis of cholesterol, and this inhibition will decrease internal cholesterol, which basically lead to the increase of LDL receptor, and more LDL will be decreased from the blood. Resins, on the other hand, they work by in bulk, positively charged. They bind to the negatively charged bile and prevent the enterohepatic reabsorption of bile salts. By this also you're going to have a decrease in cholesterol, and the decrease of cholesterol within the cell will also increase the LDL receptor. More LDL receptor, we're going to have also a decrease in LDL in the blood. And the ezetimibe works by inhibiting the absorption of cholesterol at the level of the gut. By inhibiting the absorption of cholesterol, you're also going to have a decrease in cholesterol level inside the cell, and this will also increase LDL receptor and decrease the LDL level in the blood. The niacin, on the other hand, remember, it works as a G protein coupled receptors by activating the GI and cyclic AMP, and what they do at this point, they inhibit the breakdown of triglyceride into free fatty acid to be taken back to the liver. If you have less free fatty acid in the liver, you're going to have a decrease in triglyceride synthesis in the liver, and subsequently decrease in VLDL formation. Less VLDL, you're going to have less LDL in the blood. Now remember that resins and ezetimibe can be used as an adjunct therapy to statins. They're safe, and it could be used as an adjunct therapy with statins or monotherapy in statin intolerant patients. But niacin cannot be used because niacin can increase the risk of statins side effect. Another non-statin based the drug class, the fibric acid derivatives. These are halogenated hydrocarbons. They're organic compounds, most of them, with the exception of gemfibrozil. The mechanism of action of these drugs is not really clear, but research shows they increase beta oxidation of fatty acid via PPAR alpha activation. And when you have an increase in fatty acid oxidation, you're going to have an increase in the usage of triglyceride reserve, which means that the cell is going to require more triglyceride, which will increase the clearance of triglyceride from lipoproteins such as VLDL and chylomicrons. And at the same time, it stimulates the increase in LPL expression, which makes a lot of sense. You need more triglyceride. You're gonna increase lipoprotein lipase expression to get more triglyceride from circulating VLDL and chylomicrons. At the same time, it reduced ApoC3 production. For those of you who don't know, ApoC3 inhibit the receptor-mediated clearance. So by reducing ApoC3, it also improves the clearance of lipoproteins from the circulation. The potential increase in HDL, there is an increase in HDL, is due to also PPAR alpha mediated ApoA1, ApoA2 expression. Both ApoA1 and ApoA2 are involved in the structural formation of HDL, so increasing these apoproteins will increase HDL formation. And they're also known for their antithrombotic and fibrinolytic effect, which is also a something beneficial, especially, you know, all the patients that are dyslipidemic and have high risk of coronary artery disease. They are basically at high risk of thrombosis. The therapeutic effect for the patients on these drugs, we can notice a decrease up to 50% in triglycerides. So basically, it's primarily used to manage patients with hypertriglyceridemia. And LDL levels do decrease, but not always by 20%, because the focus of this drug is to decrease triglyceride. And also, we can see a 15% increase in HDL. Now, pharmacokinetically, it's more efficient with a meal and the 95% plasma bound. The secretion of this drug is primarily by the urine, so you should be careful when you basically manage patients with kidney disease. And this is actually the case for any other drugs. If a drug is metabolized by the liver, you have to be careful. If the patient has liver failure, if it's excreted by the kidneys, you have to be careful that the patient doesn't have kidney failure, because simply you're going to have an increase in the concentration level of the drug and increased risk of toxicity. The half-life range is between 1.5 to 20 hours, depending on the drug within that class. So as we said, it's the drug of choice to severe hypertriglyceridemia. We know another drug that we talked about, the niacin. However, this drug is more well tolerated, so the compliance with this drug is higher than niacin. And decrease triglyceride by decreasing the high level of lipoproteins and chylomicron. It doesn't improve statin treatment if adjunct, so there's no point of giving it as an adjunct therapy to statins. However, you should be very careful, because remember when we talked about gemfibrozil is one of these drugs that increase inhibit the OATP1B1, which is the transporter that takes statin into the liver to be metabolized. So if you inhibit this transporter, you're going to have a risk of higher statins level in the blood, which increase the risk of statins toxicity. So you have to be careful when combining it with statins. Contraindicated in renal failure, because the concentration can drastically increase and you have toxic effects. Can cross placenta, no prescription in pregnancy, and not used in pediatric patients. PCSK9 inhibitor. This drug is one of the best non-statin dyslipidemic drug, and quite frankly my favorite drug. It's a monoclonal antibody, and it works by inhibiting the protein that stimulates the LDL receptor degradation. So usually PCSK9 bind to LDL receptor and stimulate its internalization and degradation. By inhibiting this bond, what's going to happen? You prevent LDL receptor degradation and improve LDL clearance. You have more LDL receptor, you have more LDL coming from circulation and binding to this receptor, so we improve this clearance. Now, in the next slide, we're going to see how this exactly works. Therapeutic effect is extremely high. It decreases LDL levels by up to 70%. And the compliance also is amazing, because you only need subcutaneous injections bi-weekly or monthly. So it's perfect. And no contraindication in kidney hepatic impairment, can cross placenta, not recommended in pregnancy. The only downfall of this drug is that it's a monoclonal antibody, so it's super expensive. And usually when you go to these insurance companies, they want a drug that they can afford. So they say, hey, statins, $4 or $5. Give it to the patient and let him go home. They're not gonna basically allow the coverage of such expensive but very effective drug. Now, therapeutic use is it's complementary to statins. It's not, as we said, the drug of choice given the very high price. But if the patients are really intolerant to statins and they have very high LDL and they have to be on this drug, we have to prescribe them this drug. It has very, very low risk of neurocognitive effects and no effect on myopathy, even if when it's given with statins. So we can basically combine these two drugs to have an optimum effect. The risk of infection do exist. At the end, you're talking about monoclonal antibodies, so they can cause immunosuppression and increase the risk of infection. And there's no known drug-drug interaction with really, really clean drug, dyslipidemic drug. So let's go a little bit into the detail of PCSK9 mechanism of action. If you look at this slide here, this first quadrant right here, you see you have an LDL receptor, right? And LDL particle that binds to the LDL receptor. And when it binds to the LDL receptor, the receptor is internalized with the particle by endocytosis, and then the particle goes into the lysosome to be degraded and processed, and then you have a recycling of the LDL receptor and goes back up again to pick up another LDL. Well, this is the case in the perfect world when you don't have a PCSK9. But with the presence of PCSK9, which normally exists, what happens? The PCSK9, this one, it binds to the receptor with LDL. It internalizes the receptor by endocytosis, and the receptor and the particle will go into the lysosome to be degraded. What happens at this point? You decrease LDL recycling. So if you decrease LDL receptor recycling, you're not going to have much of LDL receptor coming back to the surface, which means the efficiency of LDL clearance will decrease. So what happens at this point? The mechanism of action of the monoclonal antibody is to block this particle right here. By blocking it, what happens? The LDL will bind to the LDL receptor. In the absence of PCSK9, it will go in by endocytosis. The molecule, the LDL, will be processed in the lysosome, and the LDL receptor will be recycled and going back again. This will increase the efficiency of LDL clearance. Now imagine what happens if we combine PCSK9 and statin. So PCSK9 by itself will increase the LDL receptor recycling, so you're going to have more LDL receptor on the surface. And the statin themselves, what do they do usually? When you sense a decrease in cholesterol, because they inhibit cholesterol formation, they're going to stimulate the expression of LDL receptor. So you're going to have an increase in LDL receptor, increase in LDLR, and you're going to have an increase in LDLR recycling, right? So this is perfect. So at the same time, you're going to have an increase in LDL recycling and you're going to have an increase in LDL receptor expression. So this is a double effect in clearing LDL from the circulation. That's why it's a great drug. Moving now to omega-3. Omega-3 fatty acids are very well known. I'm sure you've heard of omega-3 fatty acids. And in the case of dyslipidemia, we focus more on the fish oil type of omega-3 fatty acid, the EPA and DHA. Now, these are over-the-counter supplements, but in the recent 2 decades, a lot of companies, pharmaceutical companies, were interested in investigating whether these drugs do have effects at the pharmaceutical dose, because they've been known to decrease triglyceride level, and which is true. The way they do that is by increasing fatty acid oxidation at the level of adipose tissue and skeletal muscle, and increasing lipoprotein lipase activity, which basically decrease the fatty acid delivery to the liver and subsequently decrease the LDL production. So this type of drug or a supplement is specifically prescribed to patients with severe hypertriglyceridemia. So it joined the league of niacin and fibrin derivative. So fibrate derivative. There's no additional effect when they're combined with statins, and most of their effects are on triglyceride. They actually do not have an effect on HDL or on LDL. They might increase LDL. A lot of trials also did not show any beneficial outcome on all cardiovascular mortality. So these drugs are only prescribed at a pharmaceutical dose when other drugs fail to decrease triglyceride levels. And we should know that they have an anticoagulant effect because they decrease thromboxane A2 supplies to the platelet. So we have to monitor them very carefully when they're given with anticoagulants. Now, the last two drugs that we're going to talk about are specifically prescribed for patients with homozygous familial hypercholesterolemia. And there's a reason behind it, because a lot of people would say, well, why don't we give them statins, these patients? The homozygous patients do have defective or mutation in both alleles of the LDL receptor. So even if you give them statin, increasing LDL receptor won't do them any good, because basically this dysfunction in the receptor will not be able to take LDL from the circulation. So you have to go and hit the LDL from the core. And what's the core of LDL, or the precursor of LDL? It's VLDL. So these drugs, the first drug is an inhibitor of MGT, or microsomal TG transfer, and microsomal TG transfer play an important role in transferring the newly synthesized triglyceride in the liver to the endoplasmic reticulum, where a nascent VLDL is ready to acquire these triglycerides and mature. So by inhibiting the MTP, you're going to inhibit VLDL formation, and what's going to happen subsequently, you're going to have less VLDL going into circulation, which will decrease LDL up to 50%. It's given orally, and usually a tolerable drug. It's metabolized in the liver via CYP3A4, so we should be very careful in polypharma of potential drug-drug interaction. So it should be used with cautiousness there. And if the adverse effect, there is diarrhea, vomiting, abdominal pain, and risk of hepatotoxicity because it's metabolized by the liver, and it's contraindicated in pregnancy due to potential fetal toxicity. The other drug is the inhibitor of ApoB100 synthesis, mipomersen. This is an antisense oligonucleotide that basically bind to the ApoB100 mRNA and degrade the ApoB100 mRNA, so you won't have any ApoB100 protein synthesis. And we know that ApoB100 is a very important component, a structural component of the LDL. So subsequently, you're going to have an inhibition via LDL formation that will lead to a decrease in LDL up to 50%. Also used for homozygous familial hypercholesterolemia, and it's given a subcutaneous injection around on monthly basis, because the half-life is high and the treatment peak within 6 months. So it's like really any antisense given, it gives flu-like symptoms, and it's contraindicated in liver disease because it has high risk of hepatotoxicity.